Okay, so good afternoon, everyone. Welcome to this special meeting brought to us by our partners at Alliant Health Insurance. The time is 1:03 p.m. Today is July 15, 2020. Officially calling this meeting to order. Attending in person are Commissioners Duncan and Filios. We're expecting Commissioner Bill Brooks to be calling in shortly. Joining us from Alliant, who have done an exemplary job for us, I might add, Scott Burkhart, Coco Brockhoff, and Dave Smith. Do we have any changes to the agenda? Hearing none, I'll turn it over to Scott. Take it away.
Great, thank you. So our presentation today will basically have three sections. David Smith is going to go through the budgetary updates and the projections. And then we set aside a section just to talk about COVID, some key points relative to Kootenai County, the health plan performance, and just things that we should be on the lookout for. I'm also going to just introduce a program called SAFE that is an Alliant program in the arena of employer return to work safety policies, testing, tracing. We're not asking for any recommendations. It's just a rapidly emerging trend nationally with all employers' organizations. And so I thought we better just introduce what Alliant is doing in that regard. We've got a meeting scheduled for Thursday, a webinar with HR and Finance. And if anything, if we decide to move further down that path, we'll circle back to the board with that. We're not making that a part of this renewal. But that'll be section 2, and then we'll talk about some recommendations and general discussions. So with that, if David, do you want to take over?
Okay, so the first thing I'll hit is the 2019-2020 performance to budget. So our fiscal year is October through September, so we have 8 months of data, which is through May. And we look at what we've projected,
Bill Brooks.
how that looks compared to what's actually happened. In summary, at this point in time, we're about $10,000 below, so we're almost right on top of what was budgeted so far to this point of the year, which is honestly a little bit better than we've been in at this position in most of the other years. There's a couple reasons for that. We haven't had the same enrollment growth that we've had in some of the years past, which really puts pressure on the budget because the budget does not adjust based on enrollment. It's a flat budget. And so when there's more employees on the plan, there's more cost, and it causes it to go up, and it causes us to do a little bit worse than maybe we're expecting if that growth happens faster. In addition, we've had some of the claims dip just a little bit, the medical claims and the dental claims because of COVID. Basically, there's a category of claims that would be considered elective. An elective doesn't mean I can choose to do it or not do it. There are some claims like that, but elective also means I can choose what time I do it. Maybe I have a cancer, but it's not a fast-spreading cancer. It's not one that's too concerning. And so they can put off that treatment until a little bit later. If I need to have a colonoscopy done, I could put that off until a little bit later. And so some people were foregoing treatments or delaying those treatments. And so we could see some of those claims come back at a certain point in time. We've certainly seen more of a dip in the dental claims and the vision claims than we've seen in the medical. For Kootenai County specifically, and really I would say we work with a lot of clients in both Idaho and Eastern Washington. And in Eastern Washington, there was more of a shutdown. And so there was a bigger change in claims we experienced over there. There was really a minor dip, and you could see it in the claims, but it was minor in not just Kootenai County, but in pretty much every client we have in northern Idaho. So a little bit less of an impact, but still an impact. And so that has caused our costs to go down a little bit. Of items to note, you'll see that there's a variance based on how we're performing by category. And you can see that the medical claims we're doing really quite a bit worse than what you'd expect at $209,000, but we're gaining that in other areas. There is some dollars that are moved around. And so what I'll mention there is, for example, this year we're getting pharmacy rebates for the first time. And we pay a higher admin for that. Those rebates were budgeted because we are counting them as claims because it really is a reduction to claims. But as they're coming through the system, they're coming in the admin billings as a reduction that we're seeing in those monthly billings. And so we're really seeing that as a positive to the admin side from what we budgeted, but then it causes a negative on the claim side. And so I wouldn't read too much into each individual line, but really, focus on the total, which is again about almost exactly even to what was projected through the 8 months. You might also recall that in times past when we have this discussion, the county performs worse in the beginning of the budget cycle, and it gets worse and gets better throughout the year. So we would anticipate that we should finish at a slight surplus as we finish the year. Those pharmacy rebates that I mentioned, they didn't begin until January, and so we're getting them every month now, but they also weren't in the first part of that fiscal year, and so that's also a plus. And so it looks pretty good at this point in time, unless, of course, we get hit with any dramatic COVID claims. And I'll talk a little bit more to that later when we get into the COVID discussion. So how does that translate into a renewal calculation? And so if we look at some of the major cost categories, what we think the admin fee is going to do, administrative services fees, and those are slightly different. The consultant fee, we're not changing that. The admin fees, you see that we're taking those up because we're accounting for the fact that those pharmacy rebates have been shown in a different category. The insurance fees and premium, everything there is fairly flat. And we're looking at, basically to project these, we take 12 months of claims and we project forward. We only use data through March for that because we know that the claims dipped in, slightly in April and May, so they're not reflective of a normal pattern. So we wanted to see what a normal pattern would do, and until claims come back to a normal level, we're not going to use more recent data. So this is going to be a fairly solid estimate for you. There are some claims that could come back due to COVID next year, but any surpluses that we gain this year will probably offset those because those surpluses are coming on the heel of the fact that we're avoiding claims that will most likely come back. Overall, we're looking at about a 4.1% overall before we look at the other components. And those other components, which we started adding last year, are the employee contributions. How much are the employees contributing for that coverage, and how has that changed? We are doing better on those employee contributions than we had budgeted. So we're not saying that you should increase the contributions at this point. This is merely reflecting that the contributions that are coming in currently are higher than what was budgeted last year because we anticipated that some spouses or other dependents may drop with the slight increase. No one did, really. And so there's more contributions coming in, and that's having a positive effect, changing that increase from a 4.1 to a 3.8%. And again, we're showing a flat enrollment. So we don't expect any new employees for the coming year. No one's really, of all of our clients, no one is projecting growth moving forward. And so that's another thing that makes this a little bit more palatable than usual. Usually we had about 4% enrollment growth. So that was causing our starting point of 4%, 5% to turn into a 10% because we had to account for that. We don't have that this year, so we're looking really at a starting point of about 3.8% if there are no changes. Any questions on that before we move forward? Nope. Okay. So talk about some COVID talking points. There are some.
There's nothing to talk
Right. So cost of testing, I'm going to go through really one aspect at a time because these all have different impacts. We did some modeling before. We had a conversation with your team about what we thought the COVID cost impacts could be. And $50 to $150 per test is what we were really estimating the average to be. And then you might also have an associated office visit, but not always, because you could go to a drive-through testing facility, or you have it when you're already in the emergency room because you have something going on. You don't have any extra added expense. And Kootenai County, we've had 35 tests so far, averaging about $77 a test. Now, there's a couple things that are going to make that a low number. Number one, the average lag on test is 45 days. And so what I mean by lag is when I get the test done, it's not showing up as paid by the plan until 45 days later. So that's a severe lag. That's not normal amount of lag, which is a delay in information that I'm receiving when I'm trying to look at what's happening. And it makes me also wonder that hospitalizations may have an even longer lag than that. And so we're really slow in finding out what's actually occurring. And that's been the problem with COVID all along, is everything in COVID is a delay from when you expect it to hit. I don't get symptoms till 10 days later. I don't get in the hospital until 10 days after that. And when people start interacting, and based on the number of people that might be asymptomatic, there might be a month before there's a reaction to a change in what's happening in the environment or with people, et cetera. And then in the claims, we won't see that data for another 2 months later. And so that causes a lot of the issues that we have in the media and different things. And so just kind of keep that in mind. So other thing is cost of medical treatment. So we're basically estimating that an inpatient stay would be between $3,000 and $6,000 per day, and most of those stays would be between 3 and 8 days. If you've seen in news that someone was in there for a month, it's in the news because that's not normal. You know, you've seen the news that someone died who was 19, that's news because it's not normal. Okay, and so always keep those things in mind. The things that make big news are usually the exception, not the rule. But it is a serious condition. And like I said, most of those between 3 to 8 days, the worst cases are usually the shorter visits because they don't end well. And when they don't end well, they're not in there for very long before that happens. And so the longer visits are usually the people that come out of it, but there's some costs associated with it. Most of the impacted individuals have currently existing conditions. Those would be diabetes, those would be hypertension. Anything really related to respiratory or heart conditions. Diabetes is related to heart and some of the effects that it causes. Those things really they cause some more problems. Being male is a pre-existing condition because we get hit a lot worse. I would also say having an A blood type. And then one of the more recent things that they're looking at is if you're on a PPI, which is a proton pump inhibitor. Those are medications that people take for heartburn, which is why I think I have this cough, because I have heartburn and I've not been taking any medication for it. Other than that, there are no claims for treatment at Kootenai County through May of 2020, so nothing I've seen yet, but like I said, there's going to be quite a lag. Who's getting hit the most? I'll say that real quick. Who's getting hit the most is Medicare. Medicare is getting hit the most because the people who have the worst effects from this are older, because they are more likely to have hypertension, diabetes, et cetera. And so employer plans aren't getting hit as much. In addition, some components of that are hitting other areas. Cost of pharmaceutical treatment. This has been all over the place, you know, and there's a couple of things you could talk about this all day. The current one in favor is remdesivir. It's an antiviral originally created for treatment of Ebola and also potentially AIDS. It's not been approved for any of those yet at this point in time, so this is its first approval for anything, which is to treat this. The cost of treatment is relatively new at about $3,100, which seems high, but I'll tell you, it's estimated to reduce the hospitalization length by about 30%. So if that cuts off 1 or 2 days at $3,000 to $8,000, $6,000 per day, it's already saving you money. And so we don't really look at that as a problematic area, especially because they're focusing that on the sickest people. If they start to do a treatment like remdesivir prophylactically, you get it and we're going to start you on this right away, that would become a problem because not everyone would ever get hospitalized, and now it's going to be an added cost. It's in a shortage right now, so I can't see that happening, to be honest. Steroids are another treatment. Those are low cost, so they don't really have too much of an impact. And immunosuppressants are high cost, and they're still looking at some of those. And usually those are used for rheumatoid arthritis and the like. Part of what kills people with this isn't necessarily the virus, but the body's reaction to the virus. You get overreactive immune system, and that hurts you more than the virus itself. And so that's why those immunosuppressants are being looked at. But those can be problematic because they're high cost, and same thing, they're more widely available. If those were used prophylactically or early, they could add. I don't necessarily see that happening. And then, of course, hydroxychloroquine. That was in the news for a long time. It still is a little bit still controversial, which means I don't really like talking about it in any recorded setting. But the simple fact is most of what's available currently does not support its usage. But you'll hear different things, and so it's an area that people should certainly be aware of, and I think people should be careful of because the treatment that was being used was that in combination with azithromycin. They both can cause heart arrhythmia individually. You put them together, it becomes a problem if you're not aware of it and you're not dosaged properly, which is where the biggest issue has been, is people kind of experimenting on their own when they shouldn't have been. Cost offsets. So those are all things that might add cost to the system. What things could reduce the cost? I had mentioned those claims that were elective, they're avoidable or delayable. Those are about 50% of claims that fall in those categories. So anytime there's a shutdown, and there could be one in the future, anywhere. I mean, it could happen at any point in time, and you cannot go to a doctor except for urgent or emergent care, The medical claims will go down to about 40% of what they are on normal. Now, of those 40%, 50% of those will probably come back, and 10% of those will never come back. And so there is some savings that's associated there. On the dental side, the number is like 80 to 90% of those claims. And a fair amount of those will come back, but some won't. Because if you can't get care for 6 months, I'm not going to go in and get 2 cleanings in a row just because I missed one. Doesn't do any good. So the other thing is dependent on months of urgent or emergent care only restrictions. When we had them in Washington, they were for a couple months, and so there was a big delay. Other parts of the country, they've had restrictions that lasted longer than that. And we could see some additional restrictions in the future. And so when those come up, we know that they're going to have an impact. And we should always account for that, not just immediately, but also knowing that some of those claims are going to get pushed off, so we'll see some really heavy months later. Kootenai County itself has seen no disruption in claims activity from the medical side. Like I said, it's a slight dip, but nothing really noticeable. Some other considerations, workers' comp is one reason why we won't see some of this. You'll see police, you'll see fire, all those things are generally going to go to workers' comp instead of going to the medical plan, so we won't see every piece of information that comes through on this, because the exposure is different. And there are other categories also where that would go to workers' comp instead of the healthcare plan. Time off is a big expense. And the reason for that is if someone is positive and they can or cannot work from home, they can't come in for a while. It'll be a while before it clears their system. And so this creates a whole different dynamic and problem for people to deal with, and is actually one of the more expensive things that businesses will have to focus on. And then revenue, to be quite frank, if it's a private company, they're going to have a hard time selling stuff, or they're going to see impacts to revenue. As a public employer, you can see impacts to the tax gains because of that. And oftentimes that'll be a bigger impact than the actual cost of COVID itself. And that's really coming true. Employer worksite safety policy, I think this is where I'm going to hand it off to Scott.
Thanks, David. This is what I introduced at the start. So obviously when we've got COVID testing, that's currently when someone's got a diagnosis, symptoms, go get a test. That's running through the health plan right now, and that will continue. Any sickness-related COVID testing, you're going to run through the health plan. But what other employers and organizations around the country are dealing with is, okay, what about worksite safety? What about testing individuals as a return to work policy? We watch on TV and pro sports teams and government officials. They say they're getting tested where are those tests coming from? Okay, there's a testing issue, a supply issue, a distribution issue. But as that's now emerging and fluid, right now the only place that I'm aware of to get a test in Kootenai County is go through Panhandle and go through Kootenai Health. Well, there are other distribution chains emerging through the pharmacies, finding the labs and getting a supply of tests and testing, your own organization. So there's going to be a lot of different protocols that employers are looking at going forward. Some employers, as Kootenai County is doing right now, is just simply dealing with the masks, sanitation, distancing. Every organization is doing some form of that. But then step it up. Some organizations might consider, both for the safety of employees and guests coming in, or customers coming in, to do some testing, random testing or baseline testing. And you can either get a supply of tests through an organization and do it yourself, find someone to administer the tests, or what Alliant chose to do, one path that we chose to explore, is a full program. The program has multiple components to it, and I'm just going to touch on a couple today. We call it our SAFE program. We partnered with an organization called STC Health, who's been in this arena for decades. They have relationships with 31,000 community pharmacies, all the big ones, Rite Aid, Walgreens, Walmart. So they've already got those established relationships and the distribution system set up. All they need to do is activate them in a given community. And this is all emerging over the last month, so this is relatively brand new. But STC Health has has dealt with the CDC and the White House Task Force. They navigated Ebola, SARS. They've been in the arena for a long time, so they know what they're doing, and they've got the relationships to be a great partner in this arena. There's 5 legs to our program. Not all of these are needed, and some of them Kootenai County's already doing, so I don't know that there would be much value. But I'm just going to focus today on the testing and the daily, the screening. The first part is simply an app on people's phones that they can download, answer a few questions every day before they come to work, and do you have any symptoms? Have you been exposed to anyone, etc. All of those results go into an employer dashboard, so you've got record every day that the employees at least are being mindful and answering some questions before they come into the work site. So, and all of this reporting is available for the employer. The bigger component is testing, okay? And this is a wide variance of different things you can do. There's 3 components right now: the molecular testing, the antibody testing, and then eventually there's going to be a vaccine available. Well, STC in this program can help with all 3 components. Right now, for the next, I think it's 6 to 8 weeks, there's molecular testing, and the costs are running, as David mentioned, around $100 per test, including the lab fee. So some employers might consider some random testing. If you got 700 employees, test 10% of those employees per week, or per every 2 weeks, or per month, and help establish some baselines of what is going on within your organization over the next 6, 12, 18 months, and adjust as necessary. You're also going to want to mix in some antibody testing to help. STC's got an epidemiologist on board as well, so they can help establish some trends. Coco and I were just talking this. We implemented this on another one of our large group, and I think they've done 300 tests so far. Every one of them's negative. So we're not sure what that means yet, whether that's great news, whether the testing's absolutely reliable or what, but that's what we're going to establish with the epidemiologists, with folks like David, and then we can figure out a plan going forward from that. So those are the basic components. There's going to be 2 delivery systems for this. Their basic setup is that it's through a voucher system. So give STC a census of all your employees. STC is going to send you vouchers for all the employees. They'll activate a Walmart, Rite Aid, etc. here locally. Employees just simply go to the pharmacy and get the test. I started to say earlier, for the next 6 to 8 weeks, it's going to be the nasal swab. Soon, the rapid testing in about 6 to 8 weeks is going to be available, and they'll be able to get results in about 15 minutes on those tests once they're available. They say about 6 to 8 weeks, but right now it's still the nasal swab. So that's one way that you can have employees tested. The other way would be to have that organization send the supply of tests here, and once a week or once every 2 weeks, you just have your employees, random set of employees come through, have one of their pharmacists or people who will take the test on site, and that's the routine. Once you get the tests, they go to the labs, and in a couple days, it's 24 to 48-hour turnaround, I think 48 to 72-hour turnaround time. You get the results, again, all through your employer dashboard, so you have an idea of what's going on. Any type of testing like this needs to be done outside the health plan, so you avoid the HIPAA issues. You cannot use, correct my language here, if I'm wrong, David, he's my checker, my legal checker. But you cannot use HIPAA information to make employment decisions, personal information. But if you do it outside the health plan, you still got the security and protections on that data, but you can start to consider employment decisions based on, COVID testing. So, am I going to jail?
Well, you are, but not for that.
Okay. Anyway, so that's the basics of the program. We're doing a national webinar tomorrow for clients and prospects, and I think Sylvia and Dorothy so far are joining that call. And so we'll elaborate on the program as a whole, and then circle back to see if there's merit in having discussions with you guys. But there are budgetary considerations. I mean, for an employer like Kootenai County to consider something like this, the cost could range, from $100,000 to $200,000, $300,000 for a full testing program. Now, what you might offset with that is identify some patterns that help save on the medical spend down the road. Right now, there's no claim activity. So are we going to see that? Potentially, we just don't know. But those are the considerations. Initially, it's an added cost. Are you saving money on the back end? We're not sure yet. So, anything else to add to that at this point?
No, I mean, with this stuff, we're not sure of anything. Yeah. And that's the quite frank reality of it. We're not going to be sure of it until 10 years from now, and then we'll know how wrong we were at that point in time. Yeah. And that's about it.
I don't see any need to recommend a program like this ASAP right now for the county. You're doing the distancing and cleanliness, staggered work shifts, it's keeping people home where appropriate. So those are all great things. This is kind of the step forward, and we'll talk more about it. So with that, we're going to switch back to the renewal and talk about some savings opportunities. We had a discussion about the limited Kootenai Care Network and kind of came to the conclusion that the idea on that definitely has merit, but we want to be really careful in how we do it because we don't want to necessarily lock ourselves into one set of providers. It might not always be the lowest cost. Is there a way we can explore things with them that are maybe a hybrid that aren't so employee intrusive? So we're going to continue those discussions, part of our recommendations here, but we also have some savings opportunities aside from that David will talk about now.
And there are several of them up there. What I will note is that not every savings opportunity has a clear-cut solution for it or a clear-cut way to get to it, but it will direct us to a certain degree on how efficiently is your plan being used currently? Are there areas of inefficiency and are areas we can improve upon? The reason we point these out is these are different than plan design. Plan design is changing your co-pays, changing your deductibles, and what you're hoping that when people have some skin in the game that they focus on using the system properly. And this looks at, okay, well, with those things in place, do we still have issues with our system and how people are using it? And so these are things that we can regularly track through all of our clients through our Dear What IDAP program. So I'll start at the top, which is drug switch. Total savings opportunity is about 56% or $56,000, which is about 2% of the category. Meaning of all your drugs, about 2% of them, maybe someone could have saved some money on because they could have taken a cheaper medication. And I don't mean cheaper medication in you took Lipitor and you could take Zocor. I mean, if you took a brand and a generic was available, if people had taken the generic every single time, you would have saved $56,000 more. The plan would have cost less. And that has an impact. It's not just, that doesn't just impact the county because as we know, when we're looking at the expenses, if your expenses are going up, that impacts the employees based on do we need to make plan design changes, do we need to make contribution changes, et cetera. So these things all matter. Avoidable emergency room visits, a savings opportunity of about $38,000 compared to 7% of the total category spent. There were 33 cases where an emergency room visit may have been avoidable, meaning they went to the emergency room for something that you could have seen at urgent care, you could have seen in an office visit. Those aren't all avoidable. We generally assume that maybe 70% of them are avoidable because unfortunately with the data that we get, we don't know what time someone went, so we don't know if they went at midnight, plus when we do know if it's your kid, and I'm sorry if it's my kid, doesn't matter what time it is, I'm taking them to the ER if I think I need to. But it's a high number of 33 cases, but as compared to our other clients, similarly, 6.8%, usually our clients are in closer to 10 to 11% range as normal, so you actually have fairly efficient usage by your employees in this category. Avoidable hospital admissions. And these are admissions to the hospital that someone had. They went inpatient for something that if they would have sought care earlier, it wouldn't have progressed to this point in time. And so there's only a few conditions that really relate to this, but asthma is one of them that can kind of pop up there. Someone's getting gradually worse and not taking something, and all of a sudden they end up in the inpatient setting. That didn't need to happen. At only 2 of those, that's honestly also quite low. Usually we're close to 3%, so you're about half of that. But there's not that many inpatient admissions in general, so it's pretty variable. I wouldn't read too much into that one. I'm going to skip the site of care optimization injectable. Really what that means is when people get injectable medications, they can go to different places. Can they go to a cheaper place than they went? Your people are being pretty effective there. Site of care optimization surgery is something different. And so one of the biggest expenses to the healthcare plan is outpatient surgery. So a lot of things that used to be inpatient setting, knee replacement, hip replacement, certain, you also have endoscopy, colonoscopy that will show up in there. Those things can happen in the outpatient hospital setting, but they can also happen in an ambulatory care setting. In an outpatient hospital setting, there is a hospital charge, and it's not light. In the ambulatory care setting, you don't have a hospital charge, and there's a big difference in expense between the two. And so there's 61 surgeries that took place, or 61 different care items that could have happened in an ambulatory care setting as opposed to a surgical setting. If we look at the average cost difference between those and those categories, there's about $376,000 opportunity there. A couple of years ago, we tried something with regions where they were going to steer care to more effective items. It was rolled out poorly and it was ineffective. But this is something that kind of tells us that opportunities still exist at some point in time if there's a solution that gets there. Now, concierge care is something that's growing. It's not been shown to be effective here yet, meaning there's not a vendor who's really focused on the North Idaho, even the Spokane area at this point in time. But as we keep reaching out to them, we want them to get focused there because that is an option, because you have to reach these people early. And you need to make it part of your plan. And what I mean by that is not part of your plan design, but when someone knows that they need something, they need to know that they reach out and they say, hey, it looks like this is going to happen, and they'll tell you the doctors who do that. What happens with these is if my primary care physician tells me to go to a specialist, and that specialist says, okay, you're going to need a surgery, and we go through the whole process, and then someone reaches out to me at that point in time and says, hey, you should use this other guy because you can go ambulatory. I'm not going to change in the middle of it. No one does. No one feels comfortable doing that. So if you get them in the right place before they get that far, that's where you can save those dollars. And so it's really trying to find something, and that's going to be a pretty big focus because that's the biggest dollar number out there. Imaging, everything's been pretty effective there. So we move to the bottom two, which are, a little bit more difficult to describe, and this is based on Johns Hopkins data. But we have care efficiency improvement diabetes. And what this really means is we can use predictive modeling to say how much your diabetics should have cost you this year, and then we can see how much they did cost you. And there's a savings opportunity of 140 grand there on 20 different cases. And so average savings is about $7,000 a case because they're costing more for their treatment. Either they're not being efficient in how they're seeking the system, or they're not managing themselves properly. And so that tells us that if we want to reach out to a program that might help with that there's a lot of meat on that bone, per se, because we're paying, if we paid for all 20 of those people to be on something, the cost would be a lot less than what we would potentially save. The last one on the bottom there is compassionate allowance conditions. And what that's really a complicated way of saying is spouses who would otherwise qualify for Medicare, either because they're conditioned and because they could qualify as disabled, and so they could be on Medicare as a disabled recipient, or because they're over 65. So it kind of combines those together. And there are 20 people averaging $10,000 that are on your plan that qualify for Medicare, or should or would or could qualify for Medicare, and maybe they've not gone through the process. Why it's important is, you're a little bit higher at 7% of the total category spent, and part of that is, we talked about the contributions, how much people pay to be on the health plan, how much the spouses pay to be on the health plan. That has an impact, because Medicare and a Medicare supplement costs a certain amount. Cost to be on your health plan costs a certain amount, and if your plan is not more expensive than Medicare and the supplement, then they're going to go your direction. So this kind of tells you that if there was a point in time when you had to save money and you wanted to increase contributions to do it, again, focusing on the spouse would potentially lead to some savings as those people moved on to something else where they had a different care treatment. The sensitive part of this is because of federal law, you have to do it through contributions. You cannot go, hey, Scott, you look disabled. I think you would qualify for Medicare. Why don't we give you some money and have you go take Medicare instead of being on our plan? You can't do that. You can't incentivize or coerce someone to leaving your plan and going to Medicare. You just have to have the plan, and then they make their own choice. Okay, and so there's a way to get to that, but the way is to change the incentives that people have to be on your plan. And so those are really the biggest focuses.
Yeah, and I'll just interject here and follow up more. There's also a component of education, as is with the other savings opportunities. That's going to be our big target. But specifically on that, there can't be any coercion, nor would you want there to be any, type of encouragement for employees to get off the plan. But you can hold opportunities for people to learn what their options are, and that's a positive thing, and it should be perceived that way. So that's something we can certainly explore. If there's might be people out there who, if they knew what the Medicare options were, they might realize it's a better situation for them. They're just on the plan because they don't know any different to do any different. And so we can help with education. The education doesn't cost anything. It's just bringing someone on site, once a quarter or something, and having a luncheon run. So.
But I have a question, but with Medicare, isn't that automatically primary and Regents backup?
No, not for a group your size. Medicare coverage, Part A, automatically kicks in when someone turns age 65.
Right.
There's also the disability component. But for a group plan, the group plan remains primary. If someone's covered under both Medicare and the self-insured health plan, the Regents portion pays first, and then Medicare comes in and coordinates as secondary. Even if someone on their own stayed on Regents and had Part A and then went and got Part B, D, and a supplement, that's still going to be secondary to the Regents plan.
To the Regents.
So there's no value for that person, to pay the Medicare premiums, also pay their contributions for the county, and then have double coverage. I mean, it's just way too much coverage. They don't need that. But when you learn what your options are on Medicare to get, I mean, we can explain. You've got on your Regents plan, and don't have them fresh in my head, but I know we've got a $500 deductible, and we've got X amount of dollars out of pocket, $3,000-ish out of pocket. If they understood on Medicare, they could kind of have first dollar coverage and very minimal out of pocket with a supplement that costs money. But they might all of a sudden weigh out, wait a minute, my current out-of-pocket expenses are this, my employee contributions are this under the Regents plan. I could take that money and move it over here to Medicare and save myself money. It's all situational. And so in that way, we're not coercing, but if it makes sense for them to voluntarily waive off the plan, we can help provide that education. Just bringing Medicare experts in once a quarter and letting them explain.
And part of it also is everyone knows when you turn 65, you qualify for Medicare, but not everyone knows when they would qualify as disability and access to Medicare. And so that's not an automatic process that everyone just automatically goes through at a certain point in time. And so you go through Social Security, qualify for disability first there, and there are certain conditions that qualify that people spend some time, 3 years maybe, not knowing that they could have been on disability for that the whole time. And so that's some of the other parts where the education can be helpful, is to let them know that.
So with that, we're kind of going to shift into some recommendations and kind of circle back to some of these opportunities and what we can do. But just want to address, so I can't recall if I mentioned this in the board meeting yet, but we're getting a stop-loss refund from Regents. 2 years ago, I believe, we implemented a proprietary language in the Regents contract, and it worked out well for the county this year, getting $86,000 back. I'm not sure if that's been received yet, but it should be on an administrative statement soon. Or else, I think they decided they might be mailing a check, so check's in the mail, so to speak. Okay. So the recommendations, these are just kind of repetitive from what we talked last time. Change life disability voluntary products from Unum to standard. There's $32,000 total savings there when you factor in the plan source costs will almost be cut in half for next year compared to what we were paying on the Ben admin system. So those are savings that with very minimal employee disruption, basically on the voluntary products, most of the disruption is in the employee's favor, either in lower rates or better coverage. So that is good news. And we talked about Delta Dental, no administration rate increase, and they'll give a 2-year rate guarantee. VSP, no administration rate increase with a 2-year rate guarantee. Alliant, no rate increase, 2-year rate guarantee. And then the major component for medical, dental, and vision, we're at this point recommending no major moves right now. With COVID and the environment, with a very modest renewal, we're just recommending if you don't have to change anything, this is not the year to make changes. So, employee contributions, no changes. However, what we can do, back to David's, there was 2 or 3 key savings opportunities, that some of that can be addressed through employee education campaigns. This year, we can, make that our focus, whether it's in the monthly newsletters we do or quarterly lunch and learns. We can get together and decide what's the best way to communicate to the employees about ambulatory surgical centers, and what's the best way to have employees engage early, as David mentioned. What's the outlet for that? Who do they call once they realize they're going to have an ankle surgery? Can we steer them? That's in the employee's best interest to lower their out-of-pocket costs to go through an ambulatory surgical center too. So it saves the county and employee money. We can work on that. And also, as I've talked about, is the Kootenai Care Limited Network. We will pursue discussions and vetting with them over the next several months, but at this point, we don't recommend implementing anything with that for this next renewal. If anything, if there is value we can incorporate with no employee disruption in 2021, we'll bring that to the board and say, hey, this is worth a try. But we want to make sure that that's coordinating with what David's doing on the analytics and those other savings opportunities. And when he showed $300,000 savings at ambulatory surgery, that's roughly 3% on the benefit plan. And remember, when I was talking about Kootenai Care Network savings, 3 to 4% of overall. So savings are pretty close, and which one has less disruption? So, with that, just a couple other considerations. I've talked to HR, and we would like to consider offering voluntary pet insurance through Liberty Mutual. It's a very popular coverage for employees. It doesn't cost the county anything, and there's no extra administration. Liberty Mutual is already offering discount home and auto to employees, but it's more of a just upfront information, and then they deal directly with the employee outside of the county, and there's no spend. I used to think this was funny to offer pet insurance, but we offered it, and it's wildly popular amongst employees. So,
I can see that.
Anyway, so that can be a positive win for the county in just offering that. And then we'll continue discussions with Alliant with us on the COVID testing program. I've talked about the budgetary considerations. But what I didn't mention is it could possibly even reduce employer liability. We just don't know what the legal landscape is going to be going forward from employees. Are they going to say, hey, I had to come back to work too early and I got sick, and so I'm going to sue my employer? All of those crazy unknowns out there. Having a formal program can help with that. But
a couple of clarifications too. On the budgetary considerations of testing costs, that's not in the 3.8% number. Because we didn't assume you're going to do it. Plus, we also couldn't assume that that's where it would fall in your budget. Because when you do a separate testing program like that, that's not necessarily part of the healthcare budget. Sometimes that's part of the property and casualty budget, or different items that you might put that in. And so it really is determined upon how you handle that, as a risk category as opposed to a health category. What was in there was the recommended change on the vendor that saved the money on plan source, et cetera. That was included in the budget projections that we provided.
yes, great clarification. So with that, that's
Okay.
So do we need to vote on that 32,000 savings, or that's just what's coming forward? Yeah, I don't know, asking.
Congrats,
For the
Sylvia.
record, I would take formal action, and your agenda is set up that way for us to switch from standard to UNUM,
Okay.
which has the,
From
UNUM
UNUM
to standard.
yeah,
Yes, we don't want to keep UNUM.
okay.
And then you'll make your decision on the budget tomorrow, I believe, so, on the other components of the budget. So I don't think they need to vote on our health insurance increase today, so just the UNUM to standard.
Okay.
Okay. So just for clarification, are we looking at 3.8 or 4.1?
It's 3.8. So the 4.1 is the total cost.
Okay.
The 3.8 is your portion of it, the accounting's portion of it, because the employees are actually a little bit higher than 4.1.
Okay.
And again, the clarification is not because their cost was going up, but just because the employee contributions that have come in this year are higher than what was budgeted.
Understood. Okay. All right. Any questions for Alliant? Bill?
No, I'm fine.
Okay. Leslie,
I'm good.
you ready for a motion?
Yep.
Go right ahead.
I move that we authorize the change from UNUM to standard products.
Is that for disability?
I second.
Life, disability, and voluntary products.
Okay, thank you for that clarification. So it's been seconded?
Bill Brooks,
Second. Aye.
Commissioner Duncan,
Aye.
Chairman Philios,
Aye, and the motion. Oh, okay. We have a cheering section. That's pretty rare. Thank you, Jim. Anyway, okay, so the motion is carried. Public comment.
Well, I would just like to know, is HSA something that we could educate on too? So if you're going to start an education campaign, can we also educate on HSAs and how that would work? Or is that?
Yes, I think that has been discussed with HR and finance, and we were going, before COVID, that was going to be one of our strategies going into this renewal was exploring either an HSA or HRA component. And with COVID, obviously, we decided to put that on hold. But if that's what we would like, the direction we would like to explore for next year, we should absolutely start education on what an HSA is. I think we're leaning more to an HRA lookalike plan because of the prescription drug component. Under an HSA, prescription drugs all have to go to that big deductible, and we thought for the county employees that might not be the best way to go. But we can do a lookalike. So education on either concept like that would definitely be something we should.
So HSA, Health Savings Account, HRA.
Yeah, health savings account, HSA. HRA is a health reimbursement account.
Reimbursement, okay.
Which is a similar vehicle, but different rules in that an HRA doesn't have to have a set medical plan design underneath it. An HSA has a government dictated, they dictate the rules on the minimum and maximum deductible and out-of-pocket. It also says that there can't be any first dollar coverage with some exceptions of preventive care. But a big part of that is prescription drug copays.
Okay.
And that's a big hit for many employees up front. Under an HRA, we could still have a high deductible. We could have a reasonable high deductible, meaning $1,000 or $2,000 or $3,000, but we could have a reasonable maximum out of pocket. But we could also put in some reasonable prescription copays where it's not as intrusive as an HSA.
Okay.
You have a lot more flexibility. in that
I like
situation.
flexibility.
And if it's, as mentioned earlier in the concierge care, if you had people reaching out and you were directing them where to go, with an HRA, you could give them a lower price going somewhere else, or waive a deductible for going somewhere versus somewhere else. You can't do that with an HSA.
Oh.
And so we kind of feel that flexibility might be more necessary for some of the plan designs that might be incorporated. Yeah, I mean, it might be 3 years from now, but the flexibility would be better for that.
Okay.
One of the downsides just with an HRA is it's got to be all employer money that's funding it. The employees don't get to put those contributions, those pre-tax savings into an HSA plan. However, we wouldn't anticipate with the county that would be a huge deal. We could set up another vehicle for employees if they wanted to put away pre-tax dollars in. Were you the one that asked the question initially? I heard it over the loudspeaker, and I'm looking back there. And
No, it's Leslie, yeah.
Yeah,
where's that voice coming from?
that would be me.
That's why I was looking around. I didn't see you ask the question. I apologize.
I have a question. Is the pet insurance currently available?
It's not
Through
currently-
Liberty?
It's not currently being offered, no.
Oh, okay.
Do we need a motion on that?
Yes.
Oh. No, well, I mean, I don't know that we need we can offer it without being a motion.
It's an offering, correct? It's
It's
not
nothing-
something that's automatic. It's something we can take advantage of.
Right. It's nothing you pay for or get paid from.
Yeah, it's not coming out of, it's, the employer isn't contributing. We're not, the county's not
Correct.
contributing towards
Correct.
this.
And we do have an agreement with Liberty Mutual, they offers, life and, home and auto. It would just be added to that.
Okay, all right.
And I believe the existing agreement is more broad, simply that Liberty Mutual can offer voluntary benefits to.
Okay,
Okay, good. That's good to know.
great.
So is that it, everyone? I see smiles. Okay. It's pet insurance. I could see why it's wildly popular. I had a woman tell me the other day to make sure I got it, so anyway, okay.
Out the bag.
Yeah. Anyway, the time is now, the meeting is adjourned. Time is 1:54. Thank you, everyone, very much.